Now, in the disease, we have relapses and we have progression. And now we have really a challenge, that the challenge is how to manage and to treat progression. Until now, that was very important to treat the relapses, but now we have so many treatments that we can treat the relapses that normally we have patients, most of our patients, they are without relapses. And when they have a relapse, it's perhaps one relapse every 10 years. So that really our problem now is how to treat the progression. And we have two components in the progression. We have a progression that is related to the relapses, associated to the relapses, so that when the patients they have a relapse, later they have a worsening associated to the relapse. That was the progression that we have seen all the last years. But now we have realized now that the patients they have no relapses, we have realized that the patients they have a progression independent of the relapses. And this progression independent of the relapses, the name is PIRA. This PIRA is responsible of the disability of the patients, is responsible of the clinical deterioration of the patients. So that we have realized we need to detect this silent progression that is part of the smoldering disease. We need to detect the silent progression, and at the same time we need to treat this progression, because this progression is doing the disability, the major disability of the patients, and is the responsible of the clinical symptoms, the worsening of the walking, the worsening of the cognitive alteration. So we need to detect and we need to treat. How to detect this progression is really not easy. It's really a very difficult question, difficult thing, because it's, in the clinical practice it's not so easy. We have a scale, the EDSS, but the EDSS is not very good, because the EDSS in the early part that can differentiate patients from one patient from the other, but later after EDSS of 4 is the same what you do all the patients that have, for example, EDSS of 6 when they have a cane, it the same as the symptoms. So how to detect in the clinical way? The first, we need to ask the patients, we need to have the perception of the patients. For example, a patient can tell us, before I was walking 5 kilometers and now I am walking 3 kilometers. So the EDSS is the same, but the patient has a difference in the walking. He can walk less than before. So that is the first symptom, the first sign that this patient is having a worsening and is coming in the progression of the disease. The second is how to detect in the way with the scales. We need to try to have different scales to try to check more the cognition with, for example, the Vicans or the BRB. We need to check the walking, but not with the EDSS, with other things like the 25 time walk test, or with the 6 walk test, or with other tests that we can have a better differentiation of the patients and the differentiation with the baseline. And we need to have other tests, for example, the PROS, the patient-related outcomes. So we need to have scales with the patients, scales about cognition and walking, what the patients are thinking about, if they have a worsening or not. And in the MRI, we need to have new outcomes, because until now, they were the T2 and T1 lesions, but they are not related with the progression. So now we are looking for other lesions, and one of them is the cells. The cells is the slowly expanding lesions, and we know that the slowly expanding lesions are clear direct related with the atrophy, with the disability, so that we can use. And how to detect the cells? The cells is better to detect with a software, a special software. We detect in the T2 sequence, that is easier, but we need to have at least three different time points. So when we have 3 different time points, we can follow the slowly expanding lesions, but to watch with the eye is very difficult, because there are very very small difference between the different time points, so that we need to have softwares. We have softwares, but at that time point, the softwares are expensive and are not integrated in the MRI. So that when these softwares, they are cheaper and they are integrated in the machine, there will be a very easy way to detect these cells and how to detect how they are progressing. And that will be a good thing to know how they are the outcomes with the patients and the response of the new treatments. Another important thing is not only the biomarkers, the blood biomarkers, and for example, the most related with the progression is the GFAP, the GFAP, and now we can detect the GFAP, because we have the machine and the hospitals to detect. Now we need to buy the kits, and now the prices are going down so that we can use in the most of the hospitals. Now we only need to validate in some hospitals, we need to validate with the new machines. But I think at the end of the year, the GFAP will be in the next years a biomarker that we will do in the clinical practice every 3 months, and we can detect when the patient is starting to progress. So that I think with all these things, the pros, the PROs, with the GFAP, with the cells in the MRI, and with the information of the patients, probably we can detect in the next years in a very easy way. We can detect the progression, and we can use this to start with the new treatments, with the new inhibitors of the BTK.